So we'll be discussing 2020 FMG questions. So the first question that came was that a 26-year-old man has an ulcer in the cervical region with overhanging and undermined edges. So there are a few important points that are asked in this question. First of all, cervical region. So what is the most important thing that's present in the cervical region? It is cervical lymph nodes. Okay, so cervical lymph nodes. And it also talks about an ulcer which has overhanging and undermined edges. So now, keeping these important things in the mind, that there are lymph nodes and there is an ulcer which has overhanging edge. So what does that indicate? So always remember that overhanging and undermined edges are present in three conditions. One is Scrofuloderma, which is tuberculosis of the skin. Then chancroid, which is a sexually transmitted disease, and this ulcer is found in the genitalia. Then pyoderma gangrenosum. It is a misnomer, even though it says pyoderma gangrenosum, but it is not caused by an infectious cause. It is an inflammatory condition. We'll just read about it. So now, we already know that lymphadenopathy can be malignant, and when they want us to mark something malignant, they will give you more clues like history of fever or weight loss or loss of appetite. So when the lymphadenopathy, they want you to mark it as malignant, they'll give you all those clues. Plus, malignant lymph nodes are very hard. Okay, none of these clues are given in this question, so most likely this is not the answer. Then reactive lymph nodes. So reactive lymph nodes would not burst into the skin forming an ulcer. So mostly reactive lymph nodes would be large lymph nodes secondary to infection, but they won't be severe enough to cause an ulceration on the skin. And syphilis is an STD. Mostly it will not cause an ulcer on the cervical area. So even without knowing anything, you should simply think that lymphadenopathy caused by TB should be the answer, and that is the correct answer. And if you know overhanging undermined edges, you will automatically mark this as the answer in this context. Okay, so now we will discuss about Scrofuloderma in our lectures, but just a brief introduction. So Scrofuloderma is tubercular infection of the skin where there is an underlying focus, and the underlying focus of tuberculosis can be a lymph node, a bone, or a joint, and this focus burst into the skin forming an ulcer. Okay, so Scrofuloderma. You can see similarly here also. So this is underlying bone, and probably there must be a focus of tuberculous infection in the bone, and which has kind of now ruptured to form this ulcer with undermined edges. This is the undermined edge, and there can be violaceous edge as well. So this is Scrofuloderma. Okay, so the answer here is lymphadenopathy of which is caused by tuberculosis, or it's also known as Scrofuloderma. So now one important thing to note about is undermined edges. As I just explained, undermined edges can be present in Scrofuloderma, chancroid, and pyoderma gangrenosum. And as I told you, these two are infections, and this is not caused by an infection. It is an inflammation. It is caused by an inflammatory cause. And pyoderma gangrenosum is very commonly present in inflammatory bowel disease like Crohn's disease and ulcerative colitis. Okay, so till now we now know about pyoderma gangrenosum, that there is an ulcer which is non-infectious and may be associated with inflammatory bowel disease, and apart from that There can be violaceous edge and all those other things that we'll further read about in the lectures. Now, this will help you to answer this next question. A patient with ulcerative colitis has an ulcer on the shin. Okay, so ulcerative colitis should ring a bell, and once you see an ulcer with violaceous edge, and if they would have given you a bonus like overhanging edge, you would have automatically marked this as pyoderma gangrenosum. Okay, so and shin is the most common site. Shin or lower leg is the most common site for pyoderma gangrenosum. So now, why are others not the answer? So let's just discount why others are not the answer of this question. You should know all these things so that, you know, even if you're not able to, even if you do not know about a particular question, you can rule out other causes and other options so that you can come to the right answer. So venous ulcer. Venous ulcer, you must have read in your surgical books. Venous ulcer is present on the medial malleolus. Okay, and can you see this is medial malleolus? No, this is not medial malleolus. This is shin. Okay, tubercular ulcer. Tubercular ulcer, we just discussed that if there would be an ulcer which is caused by tuberculosis, there has to be a focus underneath. Okay, and most common site for that focus would be cervical area. You can't see any photo of neck. So if they want you to mark this answer, they would give you a very typical location. And then chancroid is seen in it's an STI, as I told you. It's seen in genitalia. So they have not given you photo of a genitalia. They have given you photo of a leg. Okay, and then if you match everything up, you will come to the right diagnosis. Okay, so a patient with ulcerative colitis with an ulcer on the shin, it is pyoderma gangrenosum. They can also say it's inflammatory bowel disease. They can also say Crohn's disease. Okay, however, pyoderma gangrenosum is more common in ulcerative colitis than Crohn's disease. Okay. So the next question was causative organism of erysipelas. So erysipelas, as we all know, is bacterial infection of the skin. If you know nothing else, if you just know that it is bacterial infection of the skin, just exclude this answer. Okay, now remember one thing, the most common infection of skin is bacterial infection, and the most common causative organism would be staph and strep. Okay, so putting that into theory, and there's no other information given to you, you just have this picture, you just have this information. You can exclude bacteroides as well because it is not a very common infection otherwise of the skin. It is seen more in gut and intestine. So the two options that we are left with are staph and strep. Okay, now how to differentiate it? Staph is definitely most common skin infection, is the major cause of skin infection, but erysipelas and non-Bullish Impetigo in these two conditions, strep pyogenes plays a major role. Okay, so in non-Bullish Impetigo also strep plays major role, and in erysipelas also strep infection plays a major role. So causative organism for erysipelas is strep pyogenes. Okay, so this is the correct answer. Okay, and what is erysipelas? Erysipelas is a bacterial infection of the skin, and commonly you would need to differentiate it from cellulitis. We'll read about it more in our lectures. Okay, so next question that comes is, they have shown you the picture of this, and as you can see, this is an anus, and in anus there are these warty, skin colored lesions. And these would be mostly asymptomatic. Okay. So if all these things they tell you in the exam, or if they do say nothing like that, they just show you a photo and you see this is an anus and these are, the surface of these lesions are a bit rough or warty or verrucous. Okay, verrucous means rough. So automatically you will think that these could be warts. Okay, now warts, but there is no option here. What is, but the other name of warts is condyloma acuminata. Okay, acuminata means pointed. So pointed. Okay, so anogenital warts are also known as condyloma acuminata. You do not have to get confused with condyloma lata. Why? Because this is caused by lesions of secondary syphilis, and these are moist and flat. Okay, and that's the difference between condyloma lata and condyloma acuminata. Okay, so now the treatment of warts. So treatment of anogenital warts can be physical modalities or they can be medical modalities. So physical modalities include something like surgery. Okay, so we can just cut it off. Electrosurgery, so with the help of an electrocautery we can remove the warts, because warts are very superficial, so anything that can destroy the superficial surface will destroy the warts. So electrocautery. And then cryotherapy. Okay, so cryotherapy is when liquid nitrogen is used to destroy warts. Okay, so liquid nitrogen. So medical causes. In medical causes, there are very two important agents which are known as imiquimod and podophylotoxin. Okay, these are two important modalities which are used to treat anogenital warts. Okay, syncatechins are also used. Okay, but these two are the main modalities. Okay, now these two modalities are teratogenic. Okay, so they are not preferred in pregnancy. So whenever they ask you the treatment of choice of anogenital warts in pregnancy, then you have to choose one of the physical modalities because that would be more safer. Now the next question is, which is the complication associated with this condition? Okay, so now first of all, it's a two-step question. First of all, you have to identify which is this condition, and then you would come to the complication. Okay, so first of all, you have to identify what can you see here. You can see a bit of crust, and what colored crust? It is yellow, golden yellow, or honey colored crust. Or golden crust. So honey colored golden crust. Okay, whenever this description come to your question or wherever it comes, you should always think about impetigo. Okay. Now we'll read about in our lectures that impetigo is mainly divided into bullous impetigo and non-bullous impetigo. So now coming back to the basics, what is a bulla? It's a fluid-filled lesion. Okay, so now if you can see a fluid-filled lesion, then it is bullous impetigo. If you cannot see a fluid-filled lesion, it is non-bullous impetigo. So can you see a fluid-filled lesion here? No, so it is non-bullous impetigo. Okay. And now recently we just discussed here, everything is connected, so one thing leads to another. So non-bullous impetigo is most commonly caused by, one of Streptococcus pyogenes we just read is the predominant organism in erysipelas and non-bullous impetigo. And similarly, here also non-bullous impetigo is commonly caused by non-bullous, by streptococcal pyogenes. Okay, whereas Bullish Impetigo is predominantly caused by staph. So now when talking about the complication, strep pyogenes will cause most common complication as post streptococcal. You all know this abbreviation, okay? Post streptococcal glomerulonephritis. Okay, so this is the answer. So first of all, you have to identify that it is non-bullous impetigo. Then you have to know that non-bullous impetigo is commonly caused by streptococcal infection, and then streptococcus can cause a complication known as post-streptococcal glomerulonephritis. So it is a complex question with our 2 to 3 step approach. Okay, so Staph aureus, however, has a complication known as staphylococcal scalded skin syndrome, which is the 4th option. Okay, so these 2 are the main options that that could have confused you. So next time, if instead of this picture they show you picture of Bullish Impetigo, then don't be confused. Just mark answer as staphylococcus scalded skin syndrome. Now next question: a middle-aged female present with a painful finger and pus discharge, and they give you photo of this picture. They give you this picture. So what can you see in this picture? You can easily see that there is erythema of the nail folds. Okay, so erythema. This is what you can see. And what's the information given in the question stem? So that it is painful also, and it has pus discharge. So what does all these 3 things indicate? All these 3 things indicate that this is a acute infection, acute things. Whatever it's happening, it's an acute thing because there's erythema, it is painful, and there's pus discharge as well. Okay. So, and you can see that it is mostly involving area around the nail. Okay, so this condition is acute paronychia. Why paronychia? Because you can see here that the nail is apparently normal. You can't see any problem with the nail. The nail is abnormal, but the surrounding area, that is what is being affected here. So it is paronychia. Okay, so you have to also, now following the same approach, trying to rule out other option. Alopecia areata, we will read in our lecture that alopecia areata, the most characteristic sign is geometric pitting. So if they would like you to mark this answer, they will give you pitting in a geometrical pattern. They have not given you that. Okay, so nail is apparently normal. So in psoriasis also, they have given you picture of a finger. If they want you to mark psoriasis, they'll again give you coarse pitting. They'll also show features like subungual hyperkeratosis. They can also show you pictures with features like onycholysis. Okay, so these are common features of a psoriatic nail, but can you see something like this? No. The nail is apparently normal. So again, they don't want you to mark this as the answer. So we have eliminated these two options. Now onychomycosis. So onychomycosis is also fungal infection of the nail. And here again you will see that the nail plate is discolored, and there will be subungual hyperkeratosis, and there would be a splitting, separation of the nail plate from the nail bed. So all those features will be seen. So all those features, all these conditions affect the nail, but this is affecting the nail folds. So this is paronychia, and acute paronychia is most commonly caused by bacterial infections. And as we just spoke, what are the most common bacterial infections of the skin? It is staph and strep. Okay, and then chronic paronychia. So instead of this red inflamed picture, they show you a less red picture with pus discharge and with pain and with a history of chronicity. Then they might want you to mark chronic paronychia. Okay, and chronic paronychia is caused by fungal infection, most commonly Candida. And they might give you a history of a housewife who chronically has her fingers and does a lot of household work. So, these are typical questions that are asked where they want you to mark that as an answer. Okay. So now this question, 12-year-old presents with fever and polymorphic rash. So again, now few clues, how to find clues in the question. 12-year-old, that means it's a pediatric age group, has fever and polymorphic rash. So fever mostly indicate that probably they want you to look at an acute pathology. And what does a polymorphic rash means? Polymorphic, so that means multiple morphology. So a rash which has multiple morphologies. So a rash which has multiple morphologies. Okay, so what are the morphologies that can be present in a rash? So what do they all would be? The primary lesions that we primary and secondary lesions that we'll read in our basics, which are papule, macule, vesicle, bulla. So all these are morphologies that a rash can take. Okay, so a rash can have predominantly macular pathology, they can have predominantly papular pathology, but here they are saying it is a polymorphic rash. So that means there are more than one forms which are present in this rash. Okay, if you look closely, you will see in this picture there will be a small macule, there will be small papule, there will be a vesicle, and there is a crust. Okay, so there are a rash which has multiple morphologies, and it is very classical of a condition known as chickenpox, which is a viral infection of the skin, very commonly seen in pediatric age group, caused by herpes virus, which is a DNA virus. Okay, so this finishes our FMG questions for this teaser. Thank you.